going on in the main chamber, but we now move on to our next debate until we are summoned for other services. And it's an important debate about GP services in Tower Hamlets, and the protagonists are all here. It's a delight to call Mr. Jim Fitzpatrick.
Thank you, Mr. Streeter. It's a pleasure to see you in the chair this afternoon. I'm grateful to the Speaker for affording us the opportunity to have this debate, and for the Minister being here to listen and to respond, and obviously for my honourable friend, my parliamentary neighbour from Bethnal Green and Bowl, who's here to get interested and to support this debate. My remarks, Mr. Streeter, are designed to defend Tower Hamlets GP services, not to criticise them. I'm a great admirer in all that they've achieved in the last, especially in the last 15 years. I've raised this debate for three reasons: to find out more about the nature of the problem facing GP services in Tower Hamlets, to determine whether the government accepts that there is a problem, and then hopefully to identify a solution. The picture is confused. There are many aspects to be considered, but the real concern is primary care budgets are being cut, and not only in Tower Hamlets. In response to my parliamentary question 196552, the Minister said that there would be a decrease of £184,000 spread across 21 GMS practices on average annual changes in Tower Hamlets. But The Guardian reported that for the Jubilee Street practice alone, that its funding would mean that the practice would be down £77,000 by the end of 2014-15, and that it had already lost £30,000 of quality and outwards frameworks income last year, and will lose its £219,000 a year MPIG allocation incrementally over the next 7 years. The accumulated loss due to the MPIG alone amounting to over £903,000. So the first query is that the figures don't seem to add up. Of course, I'd be happy to give way.
I'm grateful to my honourable friend for giving way. As well as the surgery, Jubilee Street surgery that's been mentioned, there are 4 others that are reported to be facing closure in Tower Hamlets, along with 98 overall. We don't know where they are. Will the Minister commit today to actually publishing a list of where they are and place that list in the House of Commons Library?
Jim Fitzpatrick.
I'm grateful to my friend for asking the Minister that question, and I look forward to his response as she does in due course. As I was saying, Mr. Streeter, the Jubilee Street practice and the St Catherine's practice, which are the 2 main ones affected in my constituency, they are professional, efficient, well loved and respected by the patients. Jubilee Street says if their proposals to solve the dilemma, and they have some, are not addressed in an agreement reached, they will have to give notice of closure by October of this year. Today I accompanied my right honourable and honourable friends, the members for Leigh and Leicester West from the Shadow Health team, to visit Jubilee Street to allow them to see firsthand the problem, and to take the opportunity to launch Labour's NHS GP pledge on 40-hour appointments at the same time, which I'm sure the Minister has noticed. But what I really want to ask is, and I'll be grateful for the Minister's views, is what's causing the problems? Is it the shift from deprivation indices to age, from the new allocation funding formula from 2012? Is it the elimination of a percentage of the quality and outcomes framework indicators? Is it the 7-year phase-out of the minimum income practice guarantee?
Order. Order. I'm afraid we have a division in the main chamber. So I suggest we come back here in 15 minutes. If we come back earlier, we can start earlier. Thank you. Order, order. We resume our sitting, and we go back to Mr. Jim Fitzpatrick.
Thank you, Mr. Streeter. I had just asked the Minister 3 questions about what he thought might be causing the problems confronting our GP practices, and the 4th question was going to be whether it's the range of different contracts negotiated over the last decade, awarding different levels of funding for numbers of patients to different practices, or whether it was a shift of funding away from primary care, and if so, where the money was going. 90% of NHS contact by patients is primary care, but it receives less than 10% of the NHS spend, and I'll come back to that later. I'd be grateful also if the Minister might indicate who's making the decisions. Practices in discussion with the local clinical commissioning group and with NHS England have been unable to identify exactly who's determining what the funding levels are, and it looks as though obviously the NHS England are implementing ministerial policy, and that's why I have an outstanding request which I have briefly mentioned to the Minister to speak to the Minister responsible that I understand is the Honourable Earl Howe. And the Minister very kindly said that he would pass that on and reinforce the request that we have made directly to his office. And I would like that meeting and would be accompanied by clinicians and practice managers from Tower Hamlets to put the case. Mr Streeter, Tower Hamlets Primary Care has much to be proud of in the last 15 years. One compliment that it was paid was that it was the fastest improving primary care trust in the UK at one point. And practices like Jubilee Street have cupboards full of awards. When I was first elected in 1997, complaints about NHS services and GP practices were numerous and regular, but disappeared due to the investment by the Labour government over many years and the dedication and professionalism of clinicians and staff in primary and secondary care. My own GP practice in Ettrick Street on the Aberfeldy estate on E14 is a great example of that first-class service and improvement. And I thought I'd better mention him, Mr Streeter, because if they know I'm complimenting other practices and leave out Dr Philip Bennett-Richards and Dr Sarah Fenn and their colleagues, then they would be mightily disappointed. The worry locally is that all this is about to change. Campaigners, not only Labour stalwarts like our East London Assembly member John Biggs, our mayoral candidate, and Councillor Rachel Saunders, have been onto this issue, but also local Conservative councillors have been expressing concern. So this is not a party political issue in that sense. I attended a meeting last week at the Mile End Hospital of nearly 100 people with many GPs in attendance. I've had numerous emails from constituents who are concerned about what's going on, and I know my honourable friend has also, and there are petitions with hundreds and hundreds of signatures springing up all over Tower Hamlets. And this is against a background of increased pressure, Mr Streeter. The British Medical Association says, and I'm quoting, it is estimated that 340 million consultations are undertaken every year. This is up 40 million since 2008. And as I said before, over 90% of all contacts with the NHS occur in general practice. And the Royal College of General Physicians said, and I'm quoting their then chair of the Royal College of GPs, Dr Claire Gerada, who called for an urgent increase in general practice's share of the NHS budget from 9% to 10%, so that 10,000 more GPs could be hired in order to make GPs' workload sustainable. I'm happy to give way to my honourable friend.
I thank my honourable friend for giving way once again. Does he agree with me that in the context where you have an accident and emergency crisis, and when people can't get GPs' appointments for days on end, this is, in a borough like Tower Hamlets with high levels of health inequalities, this is a scandalous move, and it will devastate people's lives further. And actually it will cost more, particularly by putting pressure on accident emergency services.
I agree entirely with my honourable friend, and I'm sure the Minister also agrees that if we can treat people in general practice and prevent them from going to A&E, it's a much more efficient use of NHS resources. Therefore, I think the point she makes is very valid. The House of Commons Library, Mr Streeter, has produced data on GP funding. I'm quoting from a statistical table that they produced for me. It says, the table shows a shift on the share of funding from general practice from 10% in 2005-06 to 8.3% in 2012-13. The real terms change in spending over the past 3 years shows a fall of £432 million. And this is at the same time where there is an equivalent percentage decrease of 2.1% per year in GP salaries through the same period. So there you have it, Mr Streeter. 40 million increase in appointments, cuts in the share of the NHS budget, salaries falling significantly in real terms, huge variation in funding at local level, and crises affecting many local practices in my constituency, some looking at closure, which would be a disaster for some of the most vulnerable people in our country. But if I may return not only to the Jubilee Street practice, Mr Streeter, but also take the issue wider and quote from the NHS Deputy Head of Primary Care for North Central and East London, Rula Baker. She wrote recently, and I'm quoting, "The situation has unfortunately developed further, and we met with the Jubilee practice earlier this week. Although the situation with the loss of MPIG, minimum practice income guarantee, is for most practices manageable, when the practices take into account other changes in funding that impact on them, the cumulative impact is significantly greater, and practices such as Jubilee Street has said, if there is no mitigation against the loss, the practice will not be viable. I've copied in Neil Roberts, Head of Primary Care for North Central and East London, and Jane Milligan from the Commissioning Group, as discussions are ongoing about the best way forward. It's also relevant to point out that this is an issue not limited to Tower Hamlets, and we're hearing of numbers of practices in Hackney and Newham to other impoverished boroughs which are facing similar problems. The Royal College of GPs says, in total, the phasing out of a key NHS funding stream called the Minimum Practice Income Guarantee could affect a total of 1,700 practices, with the care of 12 million patients potentially under serious threat. Now, I know the Minister is deputising for his colleague, which is why I would like a face-to-face meeting with him, or indeed with the Secretary of State, but I'm keen to hear the Minister's response to the points that I've raised, and I'm sure he has some information and data for us. In Tower Hamlets, we have some of the poorest and most vulnerable people in the United Kingdom. We have the lowest life expectancy on average anywhere in the UK. It's estimated between 10 and 12% of residents are not registered on GPs' lists, and we have this crisis coming to a head. I look forward to the Minister's response. I look forward to a proper meeting with his colleague or with the Secretary of State, but most, I look forward to arriving at a solution for the patients, the staff and the clinicians to protect and continue to provide first-class primary care services in Tower Hamlets. Thank you, sir.
Thank you very much. It may help colleagues to know that this session must end at 21 minutes past 5. Now the Minister to respond, Dr. Daniel Porter.
Mr. Streeter, it's a pleasure to serve under your chairmanship, I believe now for the third time, and indeed to respond to the debate today. And I'd like to put on record my congratulations not only for the Honourable Member for Popular and Limehouse in securing this debate, but also for his advocacy on behalf of his local patients, which is something that he and I have discussed before when we've had meetings in my office in the department concerning other issues, and I am sure that my honourable friend, the noble Lord Howe, will be very happy to have a meeting with him, and I will extend that invitation on my noble friend's behalf, and I will of course be happy early on to give way.
I do apologise for intervening on the Minister very early. I don't remember having any meetings with the Minister in his office on any subject, so I wouldn't want to mislead the House on this matter, and certainly don't want people to think that we've been having meetings and have not been raising this.
No, indeed. And I had a congregation of MPs in the past from London to come to see me, and I believe the honourable member may have been with those members, but I'm obviously mistaken in that, and I apologise for that mistake. Indeed, but I recall similar conversations in the past, meeting with other interested MPs from other parts of the country, talking not just about GP services, but also about local healthcare services of a similar nature, and a strong advocacy being made of a similar nature to that which has been happening today. And indeed, we had a previous Westminster Hall debate with my honourable friend, the member for Westmoreland and Lonsdale, talking about the impact and of the minimum practice income guarantee changes in more rural practices in his constituency. This is a topic that has come to the fore for many honourable members, and something that I know honourable friends and honourable members will wish to further discuss directly with the Minister, and I'd like to, as I say, put on record a formal invitation to come and see my noble friend, the Lord Howe, to further discuss matters after this debate. Now, it may be worth, Mr. Streeter, in fact, if I were to outline some of the basis of why the minimum practice income guarantee was set up in the first place, and then also to talk about why it's important that we change that payment structure for general practice. Now, the minimum practice income guarantee is a top-up payment to some general medical services practices, it was introduced as part of the 2004 GP contract to smooth transition to what were then new funding arrangements. So it's a funding arrangement that is now 10 years out of date. And last year we announced that the minimum practice income guarantee will start to be phased out from April 2014. We consider that the minimum practice income guarantee payments to be somewhat inequitable, because under this payment system, two surgeries in the same area serving very similar populations may be paid very different amounts of money per registered patient. So the point and the reason behind the change to the and phasing out of the minimum practice income guarantee, which will be done, as the honourable members were, over a 7-year period, is to make sure that there is more equity in an area of a comparable population area between what one practice receives and another per patient, to make sure that the funding follows more accurately the patient rather than just the practice, which is something I think in principle we can all sign up to and believe is a good thing. The payments, as I said, we phase out gradually over 7 years, and the overall intention is that the funding for GP practices will be properly matched to the number of patients they service and therefore the health needs of the local population. The money released by phasing out the minimum practice income guarantee will be reinvested into the basic payments made to all general medical service practices, which are based on numbers of patients and key determinants of practice workload, such as the age and health needs of patients, and deprivation is of course a driver of the health needs of patients. And we're committed to make sure that patients have access to high quality GP services wherever they live, and ensure that in the same geographical area that similar practices receive the same amount of funding effectively for each patient that they look after. Now, it's worth also highlighting the overall impact for practices and how this is going to affect the country more generally, but particularly London. And NHS England have undertaken analysis regarding the withdrawal of the minimum practice income guarantee, and there will inevitably be a small number of practices that do lose funding as a result. NHS England have considered the very small number of significant outlier practices for which alternative arrangements may need to be made to ensure appropriate services are maintained for the local patients and local people. And we appreciate this is a matter of concern for some practices, including some that the Honourable Member has raised in his constituency in today's debate. And that's why we made the decision to take the next 7 years to implement the changes to the minimum practice income guarantee gradually, rather than in a big bang approach and a phased transition to a new funding arrangement. Phasing the changes over this period will allow the minority of practices that lose funding to adjust more gradually to the reduction of payments. It's also worth highlighting that, as the Honourable Member highlighted in his remarks, that these changes can't be seen in isolation. They need to also be seen in terms of the changes to the QOF payments and the Quality Outcomes Framework payments to GP practices, and that needs to be seen together with the minimum practice income guarantee changes. And that needs to be set alongside the global sum that is paid via the GMS to GMS practices. And it's worth, when all those changes are put together, and that the factored in the changes from the QOF payment, the minimum practice income guarantee changes, that I understand, and I will confirm if I've got this figure wrong, but I believe that the practices in London that have a GMS contract overall, and then I believe there are 721 of those practices, overall will receive an increase of £731,000 in funding as a result of the net effect of all these changes. And it may be helpful actually if I write to the Honourable Member to outline that in some detail ahead of his meeting with my noble friend the Earl Howe, and of course I will give way.
I'm very grateful to the Minister
Fitzpatrick
for giving way. He's been very generous. It would be very useful when we do have the meeting with the Noble Lord Howe, for NHS England to provide the Minister and his officials with an accurate breakdown for the practices in Tower Hamlets, because in terms of the levels of deprivation, the chronic ailments and conditions, the age profile of very elderly people and very young people, the language problems, even NHS England, as I quoted from my speech, are saying that the combination of minimum practice income guarantee and quality networks framework reductions is creating specific difficulties which are not generally replicated across the rest of London.
Indeed, and I think whilst I was very happy after this debate to write to the honourable member and outline the more general points, I'm sure we can make sure when that meeting takes place that more specific details are available to the honourable member to discuss these. And indeed, NHS England has made it very clear that they've been looking carefully through their area teams about how they can support the practices that are most affected. And they will be happy, I'm sure, to continue dialogue with local practices and indeed with the honourable member to further work out how local support could be applied if there are some practices which are struggling as a result of the changes. And that's something that an offer that has been made to the most effective practices that have already been identified, but something that NHS England are continually reviewing as a part of their process of phasing in these changes. And they've also suggested, NHS England, that for practices with very small list sizes, which may be those that are particularly affected, those practices could collaborate, work together through federating or networking or working or merging even with other nearby practices to provide more cost-effective services. They've also suggested that it would be possible to identify other ways in which practices might potentially improve cost efficiency, such as reviewing the staffing structures in those practices and reviewing other commissioning or contracting options, for example, how some other patient care services are offered in the area by collaboration. Sometimes back office costs and inefficiencies can be reduced, and that can therefore free up more money for patient care. And that's something we have to remember when GP practices on the whole are small businesses in their own right, that we do expect GPs, and that's NHS England are happy to work with GPs to support best practice and technology and to encourage general practices to collaborate and work together. But it is expected that general practices will do where they can what they can to help themselves, as well as NHS England working with them to facilitate that as a small business and as small business owners. And of course I will give way.
I recognise the suggestion he's making about smaller practices and obviously there is a degree of logic to that. The Jubilee Street practice in particular, the one I've mentioned most frequently, it's 13,000 patients. It's a big practice which is multi-handed in terms of clinicians as well as staff and is regarded as being extremely efficiently run.
Yeah, indeed, and actually, I was coming on to talk a bit more in detail about Tower Hamlets, but he's absolutely right to say in Tower Hamlets there has been a long history of collaboration, efficiently run practices, and good working between GPs and other community health services to support sometimes some of the most vulnerable people in our society, and to address specific issues of healthcare inequality, which he outlined in his speech. And that's something that local GPs should be very proud of what they've done and the work and the efforts they've been putting already in many cases to help to deliver greater efficiencies. Nevertheless, the offer is there from NHS England to engage with the area teams to see what more can be done to support, and NHS England are very keen to make sure that if particular practices do feel disadvantaged, that they will do what they can to work with the practices to mitigate against that. It's also worth highlighting, just talking briefly, as I alluded to earlier, Mr. Streeter, about the quality, the QOF, or the Quality and Outcomes Framework, and the changes that are taking place there. In addition to the changes to the Minimum Practice Income Guarantee from April this year, we've also made changes to the Quality and Outcomes Framework, and we've reduced QOF by more than a third in order to free up space and time for GPs to provide more proactive and personalised care for their patients, particularly the frail elderly. And one of the great frustrations, as we're all aware, of medical staff and healthcare staff, but particularly GPs, has been sometimes the amount of bureaucracy that GPs are required to do has got in the way of GPs being able to deliver frontline patient care and to spend time with patients. So the changes to the QOF were very much welcomed by the British Medical Association and GPs, because it does help to reduce the bureaucratic burden and allow GPs to spend more time with patients and allow greater focus on more personalised care for more vulnerable patient groups, which is something I believe all of us would think to be a very good thing and a great achievement from those GP contract negotiations. We've also retired, as part of the QOF changes, other indicators where either they are duplicating other incentives in the system, in the healthcare system, or if they're of low clinical value and use. So, for example, if they are just process measures rather than measures directly linked to patient care. So it's making sure that the payment system is strongly linked to delivering better care and improving care for patients rather than on process measures, which has sometimes been the criticism of QOF payments in the past, not least by GPs themselves. And the removal of these indicators will help to reduce bureaucracy, unnecessary patient testing, and unnecessary frequency of patient recall and recording. And the money released from the changes to QOF will be reinvested into the basic payments made to all general medical service practices, which is something I alluded to a little bit earlier on, and that is something that will be reinvested through the global sum through the GP contract. And overall, it's my understanding that practices in London with the General Medical Services contract will be net beneficiaries as a result of this, to the tune of, roughly speaking, about £700,000. So I think we can welcome that. I will give the Honourable Member exact figures in the letter that I'm writing to him, but I believe what I've given him in this debate is an accurate reflection of the situation. Now, just turning, Mr Streeter, to Tower Hamlets, and addressing some of the particular concerns that have been raised in the debate today. We do understand that there are some practices which have particular concerns about the changes to the minimum practice income guarantee and to QOF funding. And I'd like to reassure the Honourable Member and his constituents that the Government and NHS England are committed to ensuring that good, high-quality primary care for local people in the Honourable Member's constituents is a priority. And I understand that despite being one of the most deprived boroughs in London, Tower Hamlets has developed some outstanding general practices as a result very often of the hard work and dedication of the GPs themselves, wanting to address those healthcare needs, wanting to look after some of those vulnerable people in society, and wanting to make sure that those healthcare inequalities, which we've discussed in this debate, are properly addressed. And that's something that his local GPs and all healthcare staff delivering care on the ground should be very proud of. And it is top, of course, in the country, Tower Hamlets, as I believe the Honourable Member outlined, for blood pressure and cholesterol control for patients with diabetes and cholesterol, and it's resulting in reduced complications of diabetes and reduced admission for heart attacks. And it's top in London for MMR vaccination and top in London for flu vaccinations on the over 65s. And that's a very good example of how, even in one of the most deprived areas with some of the greatest healthcare needs, that local GPs, local primary care, local community care is delivering very good results for patients on the ground. And it's also one of the 14 national pioneers for integrated care, a programme in which primary care will play an increasingly important role, because if we want to keep people out of hospital, then it's vitally important that people are supported in their own homes, in their own communities, and primary care integrating with community care and effective adult social services care from the local authority will be key in delivering that. Now, I understand that NHS England's area team has set up a task and finish group to look at the support that might be offered to practices with membership drawn from local medical committees and the London office of CCG chief officers and the local area primary care commissioning team. And I understand that the NHS England's area team in London has been in regular contact with individual practices in Tower Hamlets to offer them ongoing support regarding these changes, and I'm sure after this debate that important input and dialogue will only intensify to recognise some of the issues that the Honourable Member has raised. We also recognise some of the challenges facing small practices in delivering the increasingly wide range of primary care services as more services move from hospital settings into the community, and all health services, hospital trusts, community and mental health care providers, as well as GPs, are facing challenges meeting increasing demand with small increases in funding. This demand is coming from an ageing population with increasing levels of long-term conditions, as well as the costs of new drugs and the expectations of patients. These are things that we face throughout the health service, but they are obviously acutely faced in Tower Hamlets. And local GPs recognise the need for flexibility in the way in which future services are provided, and we need to support practices to work together to demonstrate how to best use their resources for the benefit of all their patients. Mr Streeter, we have announced that the fact that we are supporting, and NHS England is supporting practices as they phase in the changes to the minimum practice income guarantee and the changes to QOF payments. There's an offer to come and meet with my noble friend, the Lord Howe, and I know that NHS England will continue to do what it can to support the local practices in Tower Hamlets. And once again, I'd like to put on record my congratulations to the Honourable Member for securing this debate, and indeed to the local GPs who deliver some of the best healthcare outcomes in England for the patients they look after.
Thank you. Question is sitting be now adjourned. Order, order. Thank you.